A new hip that dislocates is rare, and once it has, it wants to again. 1 to 5% after a primary, 10 to 25% after revision. Impingement, jump distance, and the ladder that buys stability back. Hip replacement dislocation, the complication that comes back. Impingement, jump distance, and the stability ladder, 1 to 5%, and it recurs. Chapter 1: Why hips dislocate. Stability is geometry. Watch the replaced hip. First, impingement. The prosthetic neck meets the cup rim, implant on implant, and that contact becomes the fulcrum. The classic causes: a thick or skirted neck, a small head, a malpositioned cup. Then the leg adducts and the neck levers against the rim, driving the head toward the opposite edge. The reserve that resists it is jump distance. For a hemispherical cup, roughly the head radius, modified by liner coverage and any lip. Once the head translates further than that, it escapes. Native bone covered 170 degrees. The cup covers 150 to 170, trading restraint for range. Head size buys the margin, 36 mm for most, never 28. Dual mobility's 50 mm effective head is the extreme case. And offset, restoring it with leg length and capsular tension, is the soft tissue restraint that holds everything. Here is the event itself. The prosthetic head has left the screw-fixed cup and sits displaced superolaterally, no longer articulating. The patient arrives posterior, hip flexed, adducted, internally rotated, the leg shortened 1 to 3 centimeters, trochanter prominent, unable to straight leg raise. The AP pelvis is the essential first investigation before you touch the hip. It confirms the diagnosis, shows the direction, and lets you assess cup inclination and version, impingement, loosening, wear, or a periprosthetic fracture. 75 to 80% are posterior, and the direction sets both the mechanism and the maneuver. The honest numbers: primary replacement 1 to 5%, revision 10 to 25%. By approach, posterior 2 to 5% historically, direct anterior 0.5 to 2 the lowest, anterolateral 1 to 3. Posterior carries 2 to 3 times the anterior rate, though enhanced soft tissue repair narrows it. Half of all dislocations arrive in the first 3 months, 30% from 3 to 12, 20% later. And registries worldwide, Australia, England, the Nordics, agree, dislocation is a leading indication for early revision. Chapter 2: The First Dislocation. Reduction is a sequence, not a pull. Assessment comes first, the hip flexed, adducted, internally rotated, but before anything, document the nerve, dorsiflexion, plantarflexion, sensation, both feet. Then sedation, adequate or a general, the patient supine, the assistant stabilizing the pelvis. The Ali's method: hip and knee to 90 degrees, inline traction with gentle internal rotation and rocking until the palpable clunk, then test stability. Post-reduction films, AP and lateral, confirm a concentric reduction and recheck component position, then re-examine. Sciatic nerve injury occurs in 10 to 20% of posterior dislocations, usually neuropraxia, and a worsening deficit after reduction means entrapment. Urgent imaging may be exploration. Ideal timing is within 6 hours. Contraindications: a fracture needing fixation, gross loosening, suspected infection. This is the repair that changed the numbers. Through the posterior approach, the piriformis and the remaining short external rotators are sutured with heavy braided non-absorbable, number 2 or 5, passed through a prepared osseous tunnel, and secured to restore the posterior capsule and rotator sleeve. Not a stitch of it is optional. Watch what happened to the surgeons who adopted it. Their dislocation rates collapsed. But carry the caveat with the collapse, because the exam wants both halves of that sentence. 2 surgeons, 1 identical enhanced repair. Surgeon 1, dislocation fell from 4% to 0, 395 hips each period. Surgeon 2, 6.2 to 0.8. Highly statistically significant, meticulous posterior repair should be standard of care, not optional. The honesty, sequential, not randomized, single institution, one technique. The same honesty applies to bracing. Its benefit is debated. Many surgeons reserve it for higher risk patients. Precautions are cheap. The evidence is humbler than the headline. Chapter 3: The Recurrent Dislocator. Recurrence is the rule, not the exception. After a first dislocation, recurrence runs 25 to 50%. A first episode with well-positioned components earns a brace, precautions, and a search for the cause. Non-compliance, cognitive decline, unrecognized malposition. After a second dislocation, 60 to 75%. Conservative treatment rarely succeeds now. The workup escalates thin-cut CT with 3D reconstruction to find the version error, the wear, the abductor failure. After a third, recurrence exceeds 80%, and 2 or more dislocations usually mandate revision surgery. The ladder only climbs, so find the cause before the count does. The safe zone is not a property of the cup alone, it moves with the patient. Standing and sitting laterals, here measuring the combined sagittal index, acetabular anticlination plus the pelvic femoral angle. Normally the pelvis rotates posteriorly on sitting, the sacral slope falls by roughly 20 degrees, and the cup's functional anteversion opens. A change under 10 degrees is the stiff spine, commonest cause of previous lumbar fusion, the risk rising with more fused levels, highest when fused to the sacrum. That is the red flag you can see in clinic before the operation. Hold it against the classical zones on the next card. The classical zones honestly appraised. Lewinnek 1978, 300 hips, 9 dislocations, 3%, within the safe range 1.5%, outside it 6.1. Real but a statistical guideline, not absolute. Many dislocations occur within the zones. Demotion with data. Tezuka 320 navigated hips, 92.5% sat inside Lewinnek, yet 14.2% of those lay outside the sagittal functional safe zone. The best predictor was femoral and spinopelvic mobility, not cup position. Chapter 4: Buying Stability Back. 2 ways to buy stability, both at a price. Dual mobility, a small 28 to 32 head inside a mobile polyethylene liner that articulates within the shell, an effective head near 50 mm, a large jump distance, an impingement-free arc. Dislocation 0.5 to 2% in primary use, 80 to 90% success revising instability, the gold standard there. Its costs: intraprosthetic dislocation, rare at 0.5 to 1% but devastating, and 2 bearing surfaces wearing. The constrained liner captures the head with a locking ring, 80 to 90% mechanical prevention, but reoperation runs 10 to 25% and range of motion pays. Registry honesty, 6 registries, 15,000 dual mobility hips, no all-cause revision benefit, and infection revision 1.2 against 0.8. A targeted choice, not a routine upgrade. In dual mobility, the large mobile liner is the working surface, and its specific failure is its own. This lateral film shows displacement of the head relative to the cup. In a dual mobility construct, an eccentric headliner relationship, or unexpected separation of the two, should raise suspicion of intraprosthetic dislocation, the small head dissociating from its polyethylene. Rare at 0.5 to 1% but devastating. It presents like a standard dislocation and needs open reduction and exchange of the bearing components. Not a reason to avoid the construct, a reason to read its films differently. Precautions run on a clock. From the reduction day, repeat the neurovascular examination, confirm concentric reduction on films, and document the direction of instability. Posterior precautions: no flexion past 90 degrees, no adduction past midline, no internal rotation, for a minimum of 6 weeks, often 12. The abduction brace sits in neutral to slight abduction, 15 to 20 degrees, worn round the clock at first. Anterior precautions are the mirror: no extension past neutral, no external rotation. After revision for instability, it all tightens, brace 12 weeks strictly, precautions a minimum of 12, protected weight bearing 6 weeks for ingrowth. The strongest prevention evidence with its catch: Howie's multicenter trial, 644 patients randomized to 36 against 28 mm heads, 1-year dislocation, 1.3 against 5.4%. In primaries, 0.8 against 4.4. In revisions, 4.9 against 12.2, not significant, small sample. The catch: the trial excluded patients with dementia and neuromuscular disease, the highest risk group of all. The strongest evidence for the commonest prophylactic maneuver does not cover the patients you most want it for. What to carry out of this? 1. Impingement is the trigger and jump distance is the reserve, head size buys it, offset tensions it. 2. The honest rates, 1 to 5% primary, 10 to 25 revision, posterior in 3/4. 3. The Lewinnek zones are a statistical guide, never a promise, 14.2% of safe cups were functionally unsafe. 4. Document the sciatic nerve before and after every reduction. 5. Recurrence climbs, 25 to 50, 60 to 75, over 80, so revise from the second. 6. Prevention beats revision, and the best trial evidence excludes the frailest, judge the patient, not the average. If this steadied your practice, subscribe. The total hip replacement episode is the natural first watch, and for the foot, the 5th metatarsal stress fracture lecture. Full topic at OrthoVellum.com.